Multicenter randomized trial comparing diagnostic sensitivity and cellular abundance with aggressive versus standard biliary brushing for bile duct stenosis without mass syndrome. Introduction. Cholangiocarcinoma is the most frequent cause of jaundice in patients with intraductal bile duct stricture. Bile duct drainage is often the first-line treatment in the management of such patients, but physicians should rapidly consider whether chemotherapy and/or biliopancreatic surgical resection are appropriate. Prior to such treatment, cholangiocarcinoma cytopathological characterization must be determined because 5% to 25% of indeterminate bile duct stenoses are benign, and 3% to 7% of patients who undergo surgery for a suspected malignant bile duct stenosis have a benign disease. Endoscopy plays a paramount role in cytopathological diagnosis. If there is mass syndrome, cytopathological diagnosis is easy to obtain by endoscopic ultrasound-guided fine needle biopsy. Unfortunately, where biliary stricture occurs without mass syndrome, the diagnosis of cholangiocarcinoma is difficult to obtain by biliary brushing during endoscopic retrograde cholangiopancreatography, with approximately 30% to 60% sensitivity. Among the alternatives developed to overcome the low sensitivity of biliary brushing for cholangiocarcinoma, new generation intraductal cholangioscopy with biopsies seems to be the most effective technique, with a higher but not perfect 69% to 74% diagnostic sensitivity. However, organizing such a time-consuming procedure as the first-line treatment in routine practice is complex and expensive. Intraductal cholangioscopy is also not available in every endoscopy unit. Therefore, the authors wanted to explore ways of increasing the sensitivity of biliary brushing with the aim of determining whether this sampling method could continue to be used as the first-line procedure. A more aggressive brush with a larger diameter that comprises 2 rows of stiffer bristles surrounding standard flexible bristles has recently been developed. In the very few studies published on the infinity brush, sensitivity for cholangiocarcinoma of approximately 85% and accuracy of 87% has been reported. In contrast, in an initial randomized controlled trial on 60 patients with biliary stricture, in which malignant strictures were almost all related to pancreatic cancer and not to biliary duct cancer, the infinity brush did not show any advantage in terms of sensitivity compared with the conventional cytology brush. To determine which type of brush obtains the largest quantity of cytological material, the authors performed a multicenter randomized crossover trial comparing the aggressive infinity brush with the standard RX cytology brush. The primary endpoint was the sensitivity for cholangiocarcinoma diagnosis, and the secondary endpoint was cellular abundance, as evaluated by 1. A 4-stage classification of the cellularity obtained, and 2. Blind determination of a strong outperformance of one brush compared with the other. Background. The diagnosis of cholangiocarcinoma in patients with a biliary stricture without mass syndrome can be obtained by biliary brushing with a sensitivity of approximately 50%. The authors performed a multicenter randomized crossover trial comparing the aggressive infinity brush with the standard RX cytology brush. The aims were to compare sensitivity for cholangiocarcinoma diagnosis and cellularity obtained. Methods. Biliary brushing was performed consecutively with each brush in a randomized order. Cytological material was studied with blinding to the brush type used and order. The primary endpoint was sensitivity for cholangiocarcinoma diagnosis. The secondary endpoint was the abundance of cellularity obtained with each brush, with cellularity quantified in order to determine if one brush strongly outperformed the other. Results. 51 patients were included. Final diagnoses were cholangiocarcinoma, 84%, benign, 14%, and indeterminate, 2%. Sensitivity for cholangiocarcinoma was 79% for the infinity brush versus 67% for the RX cytology brush. Cellularity was rich in 61% of cases with the infinity brush and in 20% of cases with the RX cytology brush. In terms of quantification of cellularity, the infinity brush strongly outperformed the RX cytology brush in 55% of cases, while the RX cytology brush strongly outperformed the infinity brush in 8% of cases. Conclusions. This randomized crossover trial showed that the infinity brush is not significantly more effective than the RX cytology brush for biliary stenosis without mass syndrome in terms of sensitivity for cholangiocarcinoma diagnosis, but does offer a significantly higher abundance of cellularity.